I'm just going to go over the notes that I currently have. So for chapter 20, team building, we have 8 characteristics of a high-performing team, and that's clear and elevating goal. If someone doesn't have a goal where they believe will elevate their circumstances or that it's worth their time, they're not going to be a high-performance team. You need results-driven structure. You need competent team members that have expertise and be able to bring things to the table. Because if you have team members who aren't competent, then you don't have a successful team. You need unified commitment, so everyone agreeing to do the same things, collaborative climate, standards of excellence, external support and recognition. So from the management team, making sure that you're supporting the team and giving praise and recognition for hard work will keep people motivated. And then principal leadership, so people that are in charge. So there's 4 stages of team building. Forming, so that's when the group gets together, introduces themselves, gets to know what each person can bring to the table. Storming is when they come together and they express the ideas, and this can be kind of a tricky time. People come together and have sometimes conflicting ideas, but this is a safe place to do it, and you're expressing your goals, trying to come together for a specific task. Norming is when you guys have an idea and you're working on it, and everyone agrees on it, and then performing is actually doing the work. With making assignments, as a leader, you must involve everyone in its goals, or at least get buy-in. The goals can be set by you, but if people aren't going to participate, then it's not going to be successful. And for the goals, you need goals, coordination, and accountability. So you have goals that you're going to set. The manager is going to help coordinate how to get to those goals, and then you're going to have an accountability system that makes sure that everyone's meeting those goals. Coaching should be done energizing, so making the people excited for what's happening. They could be excited about the job, positive thinking, enthusiasm. So when you're walking down the halls, making sure that you're energized and great, or feeling great about what's happening. Positive reinforcing as a manager, there's informal and formal. So informal is when you give spontaneous feedback related to behaviors that you want to see again. So you can be walking down the halls, notice someone that washes their hands as soon as they come out of the room, and you go, "Thank you for doing that." That's giving spontaneous feedback about related behaviors. Formal positive reinforcement is like an organized program, like Employee of the Month or the STAR program at St. Joe's. Counseling, when you're giving counseling as a manager, or coaching as a coaching as a manager, it should be brief, and it should be in private, and it should be documented. You don't want to call people out about counseling or things that need to be worked on in front of a group of people. You'll get a negative response to that, and it should be held brief, so it's less awkward, and you get your point across, and then it should be documented. Disciplining should be the same, so it should be brief, it should be precise, and you shouldn't sugarcoat it, because then you might lose your meeting, and the employee may not know what you're talking about, or the message might get confused. So now we're going to move into preterm and post-term newborn. So for the preterm newborn, some of the causes are unknown, but sometimes it can be due to the mother having multiple births, so gravida and parity, illness in the mother, premature rupture of membranes, placenta previa, and illness in the mother could be, chronic illnesses like diabetes and those types of things. And gestational ages from the date of conception to birth, and preterm is less than 37 weeks. And Ballard scoring is used because it determines gestational age based on external characteristics and neurodevelopment. Some typical physical characteristics of a newborn are transparent skin. The newborn will have decreased subcutaneous fat, They'll have lots of lanugo and vernix. So lanugo is the fine hair, and the vernix is like the cheese. They'll have a decreased amount of creases on their sole of their foot. They could have a protruding abdomen, and the genitalia tend to be small. And then in females, the labia majora may be open. Some problems that can occur with premature babies is respiratory function. So it's inadequate because the alveoli aren't opened up, the chest wall musculature isn't developed, they have the distended abdomen um, that causes pressure on the diaphragm, and then incomplete respiratory function in the brain, isn't fully developed yet. So one of the things that can happen is the respiratory distress syndrome, or RDS. It's also known as the hyaline membrane disease, and this is from lung immaturity. So you have a decreased amount of surfactant, and then the way we kind of a test that you can use to find this out is the LS ratio. Is one of the tests we do. So treatment is beclomethasone, IM injections in the mom 1 to 2 days before she delivers. Definitely oxygen, and then surfactant once the child is born. Signs and symptoms of RDS include respiratory rates equal to or greater than 60, your nasal flaring, cyanosis, and retraction. So basically any sort of respiratory distress kind of problems you would see in a newborn. Apnea for a newborn, the definition is a duration of greater to or equal than 20 seconds. And you can also have some bradycardia, which is in infants less than 100 beats per minute. And this is, they thought, related to immature nervous system. And the way that you combat the apnea is with gentle stimulation. Usually if you just kind of fuss with them just a little bit, they'll wake up. Suction and repositioning. So I would try the initial stimulation and repositioning, and then if you need to help with suction to kind of get their apnea, if it's they have a lot of secretions in their mouth. Neonatal hypoxia, the oxygen sat's okay if it's between 92 and 95%, according to our book. And we want to make sure that when you have your pulse oximeter on the baby, they have a matching heart rate as well. More preterm problems is heat loss, and that happens because they have a lack of brown fat, and their head has a high surface area to volume ratio, and they lose a lot of heat through their head. Also, they have poor heat regulation systems in their body. They can't shiver if they are hot. They also have an increased metabolism. So what you would want to do is just keep them warm. So you can put them in the radiant warmer, or skin to skin and things like that. So signs and symptoms of cold stress. And cold stress in an infant increases the demand of oxygen and glucose. And some signs and symptoms of that is that you'll have, of course, a decreased skin temperature. So you have a skin probe on a preterm infant. That will be decreased. They'll have an increased respiratory rate with some apnea. They'll have bradycardia, which again is less than 100. They'll have skin mottling and lethargy. Some hypoglycemia, and that's related to decreased stores of glycogen and fat. And also, if they're having cold stress, that increases their demand for glucose, so that might cause them to have hypoglycemia. And that's with preterms if the BG is less than 30. And some signs and symptoms of hypoglycemia are tremors. You'll have a weak cry, lethargy, convulsions, and then BGs for term infants is 40, and BGs less than 30 for preterm babies. Hypocalcemia can occur, and that's related to near the in the third trimester. There's a lot of calcium going to the baby through the placenta, and if it's born early, then it's not getting all of the calcium that it needs. And then you have the parathyroid that's unresponsive because it's not developed enough yet. So early is that there's early parathyroid problems is that there's a birth trauma, there's hypoxia, mom has diabetes or lack of vitamin K, and then hypocalcemia late. So later on, after the baby's born for a little bit, can happen when you give the infant cow's milk. Um, Again, because of the parathyroid, you're introducing chemicals in the body that can't um, um, help put the calcium where it needs to. And the treatment would be calcium glutamate for hypocalcemia, but you really want to watch the heart rate, because if you give the baby calcium, you could have bradycardic issues. Jaundice is also a problem with preterm babies, and that's related to an immature liver. So when your red blood cells need to be recycled and they break down, the liver's too mature to remove the bile pigment from there. So it goes out in your skin, and that's how you get your yellow color. So high levels of bilirubin can cause neurodamage, and that's why we're concerned. So the treatment for that would be phototherapy. Now we're moving on to post-term babies. So characteristics of a prolonged pregnancy include advanced gestational age. Things that can happen is also the placenta's aging. The placenta is aging. So you have decreased function, so they can get less nutrients, less oxygen that they need. You could have a decrease in amniotic fluid, which could put the cord at risk for pinching off, and that would cause decels or heart rate to drop in the baby. 7 to 10% will have post-term or related to inaccurate estimated birth date. And if they're true post-term babies, then they have increased morbidity, chance of dying, and those types of things. And these babies, these post-term babies, when they come out, will be long and thin. Their skin will be loose. They won't have as much fine hair. They could have dry, cracked skin, long nails, those types of things. Some problems with post-term babies is cephalopelvic dysportion, which is related to the mom's narrowing pelvis. And so what happens is that the fetal diameter is increased, and it's greater than the pelvic diameter. So you have the head trying to come out through a smaller hole. This can also be caused because there's a decrease in fetal descent. You can see bulging of the perineum as one of the characteristics of this happening. This can also happen in prolonged labor. And with cephalopelvic dysportion, you have an increased chance of cord prolapse, and then also increases the molding of the head of the baby because of all the pressure that's going on. Shoulder dystocia is also a huge problem, and that happens when the birth of the head happens, and then the anterior shoulder is not deliverable. So you have the head out, and the shoulder's not deliverable. And one of the interesting things that I read, and I wasn't here for this lecture, but was turtle sign. And it's basically the fetal head emerges and then retracts again. So you can see that the head is starting to be delivered, but it gets pulled back in because the shoulder, the anterior shoulder, is not deliverable. So treatments is the McRoberts maneuver or suprapubic pressure. There'll be zero fundal pressure. And babies that have shoulder dystocia, you definitely want to check for fractured clavicles, because those will break pretty easily. And then you want to monitor for Erb's palsy, and this is permanent. Also with post-term babies, they're at risk for meconium aspiration. That's when they breathe the meconium in and aspirate on it. And the treatment for that is they need to be intubated and mechanically ventilated, and then provide warmth and O2 to them. Another problem with post-term babies is polycythemia, and that's related to intrauterine hypoxia. So you have a lack of oxygen going to the baby, so the baby is going to create a lot more blood cells hoping to get more oxygen. So your hematocrit for this baby is going to be greater than 65%, and that's going to cause really thick blood. which in turn will decrease O2 and glucose to the organs because the blood isn't able to move as efficiently. So you're not efficiently moving oxygen and nutrients to your organs and other problems. And that can also lead to coagulation problems. So the way that they deal with this is that they do a partial transfusion of the blood. So they'll take some of the blood out and then transfuse just a little bit of it in. Or sometimes they'll dilute the blood a little bit with IV fluids. Okay. So here's complications of birth. So one of the complications of birth is hypovolemic shock related to postpartum hemorrhage or blood clotting disorder. So signs and symptoms of hypovolemic shock is tachycardia and tachypnea, which then leads to narrowing pulse pressures. Treatment is you find the cause and stop the bleeding. You provide oxygen, IV fluids, possible blood transfusion, and then you want to make sure you have a Foley catheter in there to assess kidney function, because with a decreased blood pressure and shocky type symptoms, your kidneys can take a hit, and you want to make sure that those kidneys survive this shock state. So early postpartum hemorrhage, and this can happen anywhere 24 hours to 6 weeks after birth. Could be related to uterine atony, and this is the most common reason for early postpartum hemorrhage. And that's when the uterus is not able to contract fully back down. So then the natural progression of the uterus is that it should be at the level of the umbilicus or UU once it's delivered, and then decrease 1 finger breath per day, and the lochia will be red. And then you will have no more than 1 chasturated pad an hour during the 4th stage of labor. But with uterine atony, you have a really boggy fundus. You have an increased fundal height, an increased amount of lochia, and you can have large blood clots. So what you need to do is massage the fundus, and that will get it nice and firm. Empty the bladder if that's the reason why the uterus is not able to contract. And then you need to have other uterine stimulation. So if massaging the fundus doesn't work, you can have breastfeeding, which releases oxytocin in your head, in your body. And then you have meds like Methergin, Pitocin, and Cytotec that could help with uterine stimulation. And if you really need to, you get into more invasive or surgical procedures to help with uterine atony. Hematomas, their characteristic is that there's severe pain that's not relieved by meds. So you give this woman pain medications and it doesn't touch it. And they sometimes will say that they have a pressure in their vulva or rectum area. And you might show signs of hypovolemic shock. Again, you have high heart rate, high respiratory rate, and a decreased blood pressure. But you kind of have like these hidden signs of blood loss because you have a hematoma, so the blood's going underneath the tissue instead of coming out. So treatments, if it's a small hematoma, then you can do ice packs with the peri-pads. The thing to remember those with ice packed or cold peri-pads is that they don't absorb as much as the regular pads when they're at room temperature. Large hematomas will need to go in for surgery for an irrigation and debridement, so an IND. Subinvolution of the uterus. So involution just means return to pregnancy size, and subinvolution is there's a decrease rate at which the uterus returns to size. So assessment for subinvolution of the uterus is fundal height, and then you have persistent lochia and pelvic pain. Endometritis is an inflammation of your endometrium, and you'll have a fever that's greater than or equal to 38 degrees Celsius. That's within the first 24 hours, or that lasts for at least 24 hours for 2 days. And then you will have a white blood cell count that may or may not be reliable, and the treatment for that is antibiotics. And mastitis, you have just use warm compresses. You'll continue to feed because it's not affecting the milk. You can get antibiotics and analgesics for pain. Chapter 11, this is communication skills and leadership. And I basically wrote down that communication in academia, number one is listening skills. And then barriers to learning and listening include confusing messages, so conflicting messages, fatigue, anxiety, and interruptions. Use of power, there's different types of power. There's expert power, and this is the strongest power that nursing has. And this is a positive and non-aggressive way to hold power, and it's based on knowledge. So you can become an expert in a certain area or in your field, and that gives you a certain type of power. Reward power is power to reward others. So this can be from a management position or those up above that are able to divvy out rewards. But you have to be fair with those rewards because it can lead to manipulation. Legitimate power is a sign-based of power, so that includes a job. So if you have a manager, if you get a manager job, that's assigned power, so that's legitimate power, and that's could be based on your hard work, knowledge, and ability because you're the best person for that job. And it's real power that's backed by administration, so someone above you is giving you that power. Coercion is an unhealthy power base. It's basically power that's meant to hurt and punish others, and there could be zero skills involved. Referent power is related to admiration and respect. So we all have someone in our life that we kind of look up to and we admire for who they are and we respect them. So that's an example of referent power. Positive influence or power promotes or influences greater good for the caring and professional. Negative power promotes your own agenda, and there tends to be power struggles. So chapter 19 is about motivating employees, and there's theory X, which is by punishment, and theory Y, which manages by Maslow's hierarchy. So theory X believes that people don't like to work, that they lack ambition, that they need control or need to be forced to work, and they dislike responsibility. And theory Y thinks that people like to work, that they could be self-made, motivated, they accept responsibility, and are creative. So theory X kind of dictates and punishes based on how they feel with disregard to the employees, and theory Y looks at what the problems are and fixes them based on Maslow's hierarchy of needs. Motivating employees, we continue that. So there's a belief in lesser value, and this is a kind of a make-do attitude. So people feel lesser than those around them and need to suffer more. So they believe that they'll just go with the status quo because they don't deserve any better. And this type of belief in lesser value kind of leads to low self-esteem, more horizontal hostility, and other negative behaviors. So people aren't happy with that, but they don't think that it should or could get any better. So there's three categories of conflict. There's competitive or opposing actions of incompatibilities. There's a mental struggle from opposing needs and drives and wishes. And there's hostile encounters and collisions. So in competitive opposing actions or incompatibilities is when some groups of people are just incompatible. This can happen from competition where it's us versus them, or it could just be choice, like racial prejudice. People choose to be prejudiced, which, anyway, that's crazy. Mental struggle from opposing or incompatible needs or wishes. So this is when people fight over distribution of scarce resources. So that could be vacation days. It could be raises, it could be, jobs or schedules that have better staffing. And what the manager needs to do is they need to work on fulfilling what those scarce resources are, so there's less conflict. So they need to figure out how to distribute the wealth evenly. Hostile encounters or collisions is just aggressive and passive aggressive behaviors. Where it plays in, you have a group going after one resource, and or like two groups of people that are going after one resource and one behaves unprofessionally. So you maybe have two groups that are trying to win grant money, and the other team is very unprofessional and sabotages your stuff. Like this creates hostile encounters or collisions. Or people can just be confronts of sabotage of another group. So you both could be applying for a job, and then this person is just outwardly sabotaging your character or name by making up lies or confronting you and telling you that you shouldn't have the job. And that creates a very hostile encounter. Moving on to healthcare environment. Chapter 4, Medicare is for those that are greater than 65 years old, and it's federally funded, and Medicaid is for low income people, and it's paid for by the states. Then you have 3 levels of healthcare. You have primary, secondary, and tertiary. And primary healthcare is doctor's offices. So this primary works on health promotion and prevention. Secondary is a hospital, so they detect and early treat like acute things. And then tertiary is like a nursing home, where you think of restorative and rehab type places. Culture is a way of life that a particular group chooses to follow. Cultural blindness is a refusal to recognize cultural needs. And cultural competence is awareness and acceptance of cultural differences. So culture is a way of life that a particular group chooses to follow. So I have nursing culture in my family. I have, some religious cultural things that are in my family. But that doesn't necessarily dictate my culture. You get bits and pieces from everywhere, and it's just the way that you choose to live. Um, Benefits of change. So Lewin's change theory. So there's 3 phases that are driven by 2 forces. So there's a driving force and a restraining force. So this is based, and this is the reasoning behind every behavior. So a driving force is what drives you to participate in a certain activity, and restraining forces is the force that has you not participate in certain behaviors. So in Lewin's theory, the 3 phases are unfreezing, moving, and freezing. And in the first phase of unfreezing, change is going to happen. You make people aware that it's going to happen, and that it's needed for progress. And they need to understand why, and that no change will happen in this step. So this is the point where you introduce the change, tell them why we're going to do it and why it's needed. And then you allow for time to adapt. So they know it's going to happen, they need to adapt. The moving phase is that they're ready for change, so they're unfrozen. Now people seem to be anxious for the start, so they know the change is happening in the first step, and now the change is happening. So during this time, you need strong support for the change. You need to teach and reinforce the changes you're making, and you have to make sure that you're only changing one thing at a time. And you need to allow time for the people that are going through the change to vent, and but you also need to reinforce and be enthusiastic for the change during this change. So that's the moving phase. And then in the refreezing phase is that the actual change has happened and it's integrated into the work. So the first phase is the unfreezing. You're telling them change is going to happen. This is why. You get buy-in. The second part is the change is happening and you're supporting the change and the growing pains. And then the refreezing is the cementing of the change and it coming into everyday work. And you have policies and procedures that kind of reinforce and make it the norm. Neuro, so nerve impulses. So a nerve impulse or an action potential, what happens at rest is or sorry, not a soul. A cell is polarized, so it has a mostly negative interior or negative electrical charge in the inside and more positive on the outside. And then an axe potential comes and it depolarizes in kind of a positive feedback loop from one end of the nerve to the other, and it can't go back, so it just moves in one direction in kind of this positive feedback loop. And you have a shift from positive outside the cell to positive inside the cell. And then you have a repolarizing phase where all the electrons are going back to normal and it can't receive another feedback once it gets to the refractory period. So there's no impulse at that point. So repolarization is the movement of positive electrons inside to outside again, and you're kind of reaching that membrane potential again. Also with neuro, we have interventions on how to decrease intracranial pressure. You want to keep the head of the bed at least 30 degrees if indicated. You want to keep that neck midline without flexing. You want to give anti-nausea medications, nausea vomiting medications, and coughing medications because vomiting and coughing will cause an increase in intracranial pressure. Stool softeners, so there's not any bearing. You want to try to decrease the amount of suction because that can elicit a vagal response, which will send increased cranial pressure. You want zero hip flexion if possible. No noxious stimuli, so that includes loud sounds, bright lights, those types of things. And then you want to space your activities out because you don't want to tire the person out, because the more things you're doing, the more activities that you have together, the higher your intracranial pressure could be. So there's some early signs and late signs of intracranial pressure. So early signs of ICP include restlessness, decreased LOC, headaches, and blurred vision. Some late signs are definitely coma. If they're fixed and dilated pupils, you have Cushing's type syndrome, where you have increased in systolic blood pressure, or in a waning pulse pressure, so your diastolic stays the same, but your systolic goes through the roof. And then flaccid and decorticate type of movements are all very late signs of ICP. For tonic-clonic grand mal seizures, I kind of just wrote down the events that happen. So they could or could not have an aura that happens. And then they go in their rigidity type state where they're super rigid, and then they go into a relaxed state that includes kind of jerky movements. So this is where you have the more like movie type seizures that people have. So this can go on for a little while, and then you have a post-ictal state where they sleep, and that can last anywhere from 30 minutes to a couple hours, depending on how bad the situation is. So the number one thing with any sort of seizures is that you want to make sure that the airway is patent and prevent injury, and you can help prevent or have a patent airway by turning them on their side if it's safe, just in case they vomit. It comes out instead of them aspirating on it. So that's the only kind of things I wrote down for that. Signs and symptoms of MS. So triggers for MS include heat or extreme heat and cold, fatigue, infection, and stress. And stress could be illnesses or major life events like pregnancy. So signs and symptoms of MS include weakness and paralysis. You can have diplopia or double vision, slurred speech, spastic muscles, numbness, tingling, patchy blindness, vertigo, tinnitus, ataxia. You have incontinence issues, anger, and sexual dysfunction. Viral meningitis and pain. So you want to use non-narcotic pain medications that don't affect your level of consciousness. And the book recommends codeine or NSAIDs. So craniotomy assessments. So I would monitor the ICP Monitor drainage. You might have to use osmotic diuretics, depending on your ICP, to kind of reduce pressure and pull the fluid from the intracranial space to the vascular spaces. You don't want to hyperventilate these people unless it's nothing else is working. You want to help regulate their body temperature. Definitely neurochecks and fluid statuses. So you need that Foley catheter in as well. Complications of surgery could be craniotomies, could be herniation, diabetes insipidus, because you're pushing on all those wonderful structures. Hydrocephalus, you can have labile vital signs, PTSD, and then changes definitely in function and personality of the brain. Spinal shock, and that could last a week to more than a week. And some of the things you see with spinal shock is vasodilation, hypotension, bradycardia, because you have that vasodilation, and bradycardia, urine and feces retention, because you're not getting a sympathetic responses to those areas. You can definitely have hypothermia because blood isn't moving around like it should. And then you definitely have reflexes below the injured site are lost for spinal shock. So PEDS disorders. Tetralogy of Fallot, you have, that's a defect that has, a disorder that has 4 defects. So you have ventral septal defect, you have pulmonic stenosis, right ventricular hypertrophy, and then an overbearing aorta. And these kids are born with cyanosis, and then as they get older, they get kind of a blue hue to their skin. If you have an X-ray, these people can have like a boot-shaped heart because of their right ventricular hypertrophy, kind of makes it look like a boot, or this time of year, like a stocking. And these kids will have little TET spells. So they have more deoxygenated blood running through their systems. So when they're running around, they're using up all the oxygen and they're not able to get enough. So these kids will squat to increase their pressure, and it kind of helps get more oxygen through their body because they're vasoconstricting their body. And these kids also have polycythemia. So if you have hypoxia, you're going to have polycythemia, or long-term hypoxia. You have polycythemia because your body is trying to make up for the fact that you don't have enough hemoglobin. VSD, or ventral septal defects. This is when you have right ventricular hypertrophy, which increases pulmonary pressures. So you'll hear a loud, harsh systolic murmur on the left sternal border. And sometimes you can feel the thrill. And these kids fatigue easily. Atrial septal defect, or ASD, is blood flow goes from left to right instead of right to left. And this has a harsh systolic murmur that you can see in the second and third intercostal spaces. And there's a definite split-second heart sound with that. Cortication of your aorta. You have an increased blood pressure in your upper extremities. You can have headaches, nosebleeds, hypertension in adults. Oops. Let me see, what did I do? There we go. And these, also with the cortication of the aorta, you won't have a femoral pulse, which is interesting. Anyway, I think that's all of my notes. If you have any questions, just let me know.